our stroke champions, Dr. Trudi Carter, about the support network that she is putting together in the Los Angeles area, along with Diane Stewart, who's the Senior Director from Pacific Business Group on Health. So to clarify here, you can't hear me.
Oh,
you decided to flip it?
Switch, yeah.
Okay, so I'll just say that I'm going to introduce you both at the same time. Diane Stewart, please join us. And Pacific Business Group on Health has a contract to provide support for quality improvement. We'll be learning about that together in just a minute. And Trudi Carter will follow about what she's doing in Southern California along the same lines. Thank you.
Great, thanks, Hattie. That was amazing. When I spent a lot of my career trying to figure out how to scale best practices. That was an amazing presentation. Thank you. So I am now going to be talking about a program offered through CMS to provide funding for practice transformation. I think the simplest way to explain it is providing funding to clinicians and practices to get from where we are now to what Arnie described. What's the roadmap to get from where we are to Dr. Fine? It's really your question, or at least it's a part of your question. So CMS, through the Transforming Clinical Practice Initiative, is committing $685 million to 29 organizations around the country to support practice transformation. And you will hear from two of those 29 today. There are 3 practice transformation networks headquartered here in California. CQC, Pacific Business Group on Health, has one, and LA Care has another. And how do we get from where we are to where we want to be? We are very fortunate in California to have some thought leaders in that area. At UCSF, Tom Bodenheimer and Kevin Grumbach. Their 10 building blocks lays out sort of a roadmap on how we do that work. So let me just finish a little bit more about the overall CMS's vision for the program, and then I'll tell you a little bit about how we're running the program at PBGH, and Dr. Carter will share with you how they're doing it at LA Care. As I mentioned, we're one of 3 at PBGH. In addition to the 2 you'll be hearing from today, there's a pediatric focus program at CHOC, and partnering with San Diego Rades Hospital to focus on pediatric practices. CMS's goals are very much along the triple aim and really the 4th aim. They've at least verbally acknowledged the need to improve joy in practice as we do this work, and as thankfully Arnie found in the work as he among those high-performing practices. So their goal is to engage 140,000 clinicians around the country. We are required to collect and report data at the NPI level. They're designing this as a quality improvement program, not as a public reporting program. So we're collecting data that can be used for improving these practices to deliver better outcomes for patients. Now shifting to the program that I work with, it's a partnership between the California Quality Collaborative, Integrated Healthcare Association, many of you know. They are our data aggregator. They'll be accepting the data from the practices and provider organizations who are participating in the program. Center for Care Innovations, you may not know, they've done great work in improving care in the safety net, because we'll be working with community clinics. Is my voice okay?
It sounds good here.
It does, okay, great. They've done some great work in spreading innovation in the community clinics here in California. So our goals, pretty much aligned with CMS's goals. We'll be working with 4,800 clinicians. Our approach is to work with provider organizations. I'll share with you who some of those are, and provide about half of the funding that we receive from CMS will be going out to those provider organizations to hire coaches to work directly with the clinicians. These are the measures that are part of our program. We chose these measures because they are very common across all P4P programs, value-based payment programs across all business lines, Medi-Cal, commercial, Medicare. And as I mentioned, we'll be collecting we're not requiring all the provider organizations we work with to report on all of these measures, but a subset that is most relevant to the populations that they serve. But we do want to work with all practice, although this is a CMS program, we want to work with improving care for all patients within that practice. The way we're structuring our model, and then I'll tell you how you all can help. We are contracted with provider organizations. They are community clinics, IPAs, medical groups. We actually have a health plan, Molina Health Plan, who's part of this program. We provide funding at the level that you see here, $1,700 per clinician, to hire a coach to work directly with that clinician practice. We train those coaches on the skill set that they need, both the soft skills and the hard skills to do practice transformation. We provide a learning network for those coaches that are hired by the organizations, and also for the leadership of the organizations that are part of this program. And then through IHA, we provide some dashboards and feedback reports so they can both understand the variation within their own systems and their opportunities to improve. So how can all of you in the program participate? We have 15 organizations signed up now. We have room for probably 3 or 4 more organizations to participate. We're looking for, again, community clinics, IPAs, medical groups. We're actually working with a health plan that is interested in working with a minimum of 200 clinicians in this program. The ability to work, to be able to collect and report data at the MPI level is an important consideration. So if you're a provider organization and interested in this, we'd love to talk to you. As a health plan, we're also going to experiment with how do we work with practices that don't have close associations with IPAs or medical groups. And we're working with a CHIPI, I won't go into what that is, but a multi-payer database to understand where in the state there are practices that are really struggling to do well, particularly in the chronic care measures. And we're thankful for Blue Shield for leading a lot of that work, along with Anthem, HealthNet, and Molina. As a researcher, so for health plans, we're interested in working with some independent practices in regions of the state where we're really struggling to do well. As researchers, we really want to try and understand what it takes to scale this kind of work, and helping us understand, learning from our experience as we go along. It's a 4-year program, goes through 2019, and a common question is, given the changes in the last week, will it continue? And this is run through CMS with appropriated dollars. We have every reason to believe that there won't be any change in the program. Yes. So thank you. I'll turn it over to Dr. Carter.
Thank you very much. I'm down, I think Diane was up here. I'm gonna take it down a little lower. Let's go here. Diane talked about it. I wanna talk about why LA Care decided to join the grant. The first reason was really about our passion for the safety net. As you know, we're a predominantly Medi-Cal plan in Southern California. We have about 2 million members right now, and of those 2 million members, 1.8 million of them are Medi-Cal. And we work with our safety net very, very, very closely. And so we're always looking at how can we improve the care given by the safety net in every way we can. We saw this as an opportunity to do work around access and availability. With the ACA, we almost doubled in the last 3 to 4 years in our membership without doubling the doctor base and the service base that we had. So an opportunity to work to see if we could improve practices and by that way improving access and availability and the quality of the care for our members was very enticing. We also wanted to have an opportunity as a health plan to work more closely at the practice site. Our plan that's totally delegated in all kinds of ways. We have health plans that we delegate to, Anthem, Kaiser, and Care First, now Blue Shield. Besides the community clinics, we have a large contract with the County of LA, which is the County of LA, which is very different. Then we have the large IPAs that a lot of you have. And most importantly, we have a large number of what we call traditional Medi-Cal providers. Medi-Cal providers who are in 1 to 5 person groups, who have been in very disadvantaged communities for a long time. And these providers are older. I would say the average age is somewhere in the late 50s, maybe early 60s. And we realized that they were really, really struggling. So again, the opportunity to be in a pilot where we could model how do you help these various levels of practice was very interesting to us. Plus, we wanted to leverage some of the investment that we had already made in our community. We had been a part of the High Tech LA, where we had invested and provided 3,000 of our primary cares with electronic medical record funding. And we're kind of disappointed that when we recently audited them, less than 20% of them were really using the electronic medical records that we had struggled to get into their office in their entirety. I mean, we had some of them that used it like an electronic data appointment book, but not in the sense that the practice could really leverage and use. We had also have been thinking and are getting ready to invest in doing training, and we're looking at having training for community health workers, also training for office staff in the primary care offices. So, and wanting to get an idea on how we could leverage that work. And finally, we've been looking at alternative staffing for the doctors in the offices, and looking at investing in social workers and behavioral health staffing that again could help them. So this was, God sent. We were anxious to participate. The only thing I had to do was to convince the organization that this was the last time I was going to ask for them to go out on the limb and invest. But I had my fingers crossed when I made that promise. These are the goals of our pilot. And as you can see, likewise, they cover the HEDIS measures as well as some utilization management measures. These are our partners. As I mentioned, DHS is a major partner. We have almost 300,000 of our members with the Department of Health Services. Since our pilot was on diabetes and behavioral health and depression particularly, we were very, very happy to get the LA County Department of Mental Health to also be a participant with us. The Clinic Association, as you can see, Glendale Adventist Medical Center, were really primary care doctors, and Citrus Valley Independent, the IPA primary care, very small group practice doctors. What have been our learnings? Well, one thing, the first learning is you have to be careful in engaging who you want in a pilot. I'm laughing because Greg's looking at me and he knows that I can be pretty direct. So there were a lot of people who initially wanted to be a part, but they wanted to be a part by well, give us the money and we'll do what we want to do. Or they wanted to be a part on that, okay, let me get this straight. You do everything and just use our name. Or, you know, those kind of things. So I had to be really pretty rigid about making sure that the participants understood what was going to be, that this was not my project, this was their participation, their project, and there was work to be done on their side. And I think that we ended up, it took longer than we thought to get the final group, but I'm very happy with the participants, and they have been doing a really good job. I think the second learning, as you can see, it was about the data collection. It's been very challenging because we have, you know, all kinds of medical records. When the doctor was talking about Kaiser, you know, I always get this little bit of envy to have one set of medical records instead of having, you know, thousands out there. But we've done a lot of work. We have a very strong health plan, IS department, and a very strong health plan, health outcomes and analysis. And this has given us an opportunity to sharpen our pencils and work really hard on using the various EHRs and health information exchanges to try to pull in the data. It's still, I have to admit to you guys, it's still a large manual component in getting the data so far. Which is why, again, I go back to number one, having really cooperative participants who knew that there would be some manual work on their part was very helpful. The second thing, as you can see, is that emergence of the quality and the behavior health. One of the areas that we found that even in the big community clinics, they didn't have staff who only did quality improvement. You know, when you're in a health plan, you automatically say, well, the quality people will do this. Well, out in the community, there are no quality people there. So we've done some work on designating certain people in the practice who kind of serve as the de facto quality person. Oftentimes, it can be, a lot of the practices don't have RNs, but they have our LVNs that you can, and we've done training to help them, help us to make sure that the quality improvement part of the grant is being done. Plus, we have created internally we have a behavior health department, and we've been training and working on behavior health staff that can also go out and literally be in the offices to help the staff on with behavior health. The other area that we found that the health plan has really helped a lot is that we do have a social service department, and oftentimes the social service can also help in being into the office and helping. Very similar to what Diane talked about, we have coaches. We also gave the money and allowed the entities to hire the coach that they use. We do the training of the coaches, and we oversee, very similar to Diane's infrastructure. But it's given us, by being out in the offices, we really learned a lot about how hard it is to be a primary care in healthcare today. I mean, you know, a lot of times, I don't know about you guys, but I sit at the health plan level, and it only takes like one time in the office to see why primary cares have such a difficult time now trying to do the work that that they have to do. And it really doubled our efforts to figure out what is it that we can do at the health plan so that we don't have to ask them to do one more thing. And also we are hoping that the processes and the program that we put in, they can use for any payer. You know, it's not just for LA Care. If we can have a uniform way where they're collecting data and it's easy for them to do, because most of our practitioners have more than one health plan. I mean, they're not Kaiser. So they'll have, you know, LA Care, they'll have Anthem, they'll have Care First and Health Net, Molina, and we're not trying to put in an LA Care process. We're really trying to help the provider put in a process that's going to help him or her. I think the big thing, and I'll end with this, is that we never saw this as a grant that was just going to have a beginning and an end. The only reason we got into it is that we really hoped that this would help the provider and that it would be life-changing for them. We want them to be happier. We don't want them leaving practice early. We don't want them, we need them, and we express that to them in very real ways and saying, join us, help us figure out how to make your life better for the next 10 years, if they're lucky, but at least even for the next 5 years for some of those guys. We are really also saying, you don't have to do it all yourself. Let's talk about teams. Let's talk about how to leverage the people in your office. Let us help you train them so that they can be more available to help you have the kind of practice that you want to have. I end finally by saying I'm a pediatrician, and when I was in practice, and I practiced for about 10, 12 years, I loved it. I loved my patients. I couldn't wait for them to come in. Even back then, I won't tell you what year it was, 1977. Even back then, it was, there was always administrative work, you know, paperwork that you had to do. But there was a joy that I had. And you know, I talk to our doctors now, and they don't have that joy anymore. You know, if you talk to them long enough, they'll start to tell you about the patients. And you know that the joy is still there. But they don't have it the way I think, you know, we used to have it. So I think one of the things for LA Care, and for me personally, is to fan the flame of you're doing this because of the patient, you're doing this because of the member, you're doing this, and not that you're doing it to meet the HEDA score, or you're doing it to check the box. And everything that we can do to help these physicians be the physicians that they want to be, I think is worthwhile. So I'm glad that the government has given us some money to do that work, and we're looking forward to this grant. And we think that at the end of it, we're going to have, it's called transformation. We're hoping we're going to have true transformation. Thank you.
We have 2 minutes for questions for Diane and Trudi, so please.
I was wondering about training and skill set for practice facilitators. You know, we used to call them MHAs or MBAs in healthcare. And it sounds like you guys potentially have folks being trained on this, maybe without.
And AHRQ has some great guides on practice facilitation programs. And I don't know, I'd be curious, I think we've found it's more the soft skill set that's more important than the licensure or formal training.
It really is. I think a big piece is the training, but also looking for people who really can interact with the physicians and with their staff. The staff is a huge part of this exercise, because we think the doctor runs his office. Not really. So it's the staff and having a facilitator who can kind of work both sides with the docs, with the staff, and with the health plan, because we oversee them, making sure that the message and the work that they're doing is what we want to happen.
So, have you seen any efficiencies in the ability of these teams, you know, with the physician and the office staff to see more patients yet maintain the quality?
Not yet. I mean, a lot of the work this first year has really been just getting the physicians of the mindset that they can change. They say they want to change and they're interested in change, but when you really, the first thing when you say, well, we want you to use the electronic medical record and you pull this report, all of a sudden it's like, really? That's what you really want us to do? So a lot of the work has been really working with the office and with the doc to say this is part of it, this is what you have to do, and helping them to feel comfortable doing that. I think once that happens, and well, let me say one other thing. As a health plan, we're kind of screwy too, because we're trying to figure out how to be there to help and not just to do it. So I think that both of us working together will start to see some efficiencies, but not yet.
Yeah, I think just to reiterate what you said, it's really about building the care team, and some practices are so small that the team is just the receptionist, the wife of the doctor is the common term. So how do you build a team around that practice comes up, and then how, and then what we're also discovering too is how do you affect the payment model so that it rewards building that care team around the practice, because the physician alone can't do it.
If there aren't more questions right now, we have lunch waiting for us. And we've got half an hour to get our lunch and eat it quickly. And then back here in 30 minutes, please. Thank you.